Hi, I'm Graham from Match Medics, and welcome to our podcast, Doctor Diaries Adventures to Ireland, where each week we have a doctor come on to tell us their own personal story about relocating to Ireland. Thank you, PJ, for joining us on our podcast, Doctor Diaries Adventures to Ireland. Thanks for taking the time to come up to wet Dublin this morning.
Very welcome. Delighted to be here.
Yeah. So for anyone who doesn't know, tell us a little bit about you and Mowlam Healthcare that you're working with.
Yeah. Well, I trained originally as a psychiatric nurse many years ago in the UK, and then came back to Ireland in around the year 2000, having worked there for 17 or so years in various roles. And since coming back, I've worked in various roles in Ireland as a hospital CEO, as Department of Health system improvement team, part of the clinical programs, and more recently for Mowlam Healthcare. So I've spent about, before I joined Mowlam, which is a year and a half ago, I spent 25 years working in the Irish health system in various roles, and very often in system improvement and quality improvement type roles, as well as managerial and educational roles. So I've kind of done a lot of various jobs, and perhaps master of none. But
Sure. And we'll delve into the relationship between public and private health systems in a short while, but maybe can we jump into Mowlam Healthcare for now and tell us what's the initial service offering, and then what brings us to chatting today about your
so
service.
Mowlam has been established over 25 years, initially by Joe Hanrahan and Pat Shanahan, and it's grown over the years from one or two homes to over 35 facilities now.
This is the nursing home care side of the
nursing
business.
home. So nursing home care was the origins of Mowlam, and so predominantly until about a year and a half, 2 years ago, the main focus of Mowlam Healthcare was on long-term care and memory care. And the reason that I joined Mowlam, that they approached me to join, was to help them to diversify into other areas of healthcare provision, but also as head of integrated care, to help Mowlam to integrate into a wider health system, to be part of an ecosystem of care. And as head of integrated care in particular, the logic behind that role would be to look at how Mowlam can complement and augment the wider healthcare system. So in Ireland, as you know, there's roughly 50% of healthcare provision is privately provided, both in terms of primary care, but also private hospitals. So our strategy is to be part of that ecosystem of care. And so the design of our models of care is very much with that in mind. So Mowlam is now diversifying into rehabilitation. It also has a number of post-acute step-down beds, which sort of term that's commonly used. But more and more we're working towards a model whereby if in a strategic development we would look at what's the need for long-term care in a particular area, and then within that area might there be a need for rehabilitation beds. And that's really in response to a number of things that have happened over the last 10 years in the Irish health system, in particular since 2017, with the launch of Sláinte Care, which is the Irish healthcare policy and strategy. We've been sort of seeking to mirror what it is that strategy wants to achieve, and Mowlam to fit into that broader strategic plan.
Okay. And when we talk about the Irish healthcare ecosystem and the drive towards this elderly care model, has that been driven by our rapidly growing aging population, as well as the stretched public system for bed capacity? Bed capacity is a big thing when it comes to the national press and its relationship with healthcare. Talk us through Mowlam's thinking with this diversification on those two fronts.
Yeah, so I think in the last 18 months alone, Mowlam has added on, significant bed capacity. So up to about 2 years ago, Mowlam had something like 2,000 beds, either directly managed by Mowlam or managed by Mowlam on behalf of the HSE. So facilities that may be owned by the HSE are run by Mowlam in in the instance, let's say, of Ballincollig, which is a long-term care facility, or Mount Carmel Hospital, which is a rehabilitation facility. So Mowlam had in the region of 2,000 beds under management. That's about 2,000 staff. I have, in previous roles, I worked as the national program lead for the integrated care program for older people. So that gave me a lot of visibility of what was happening both nationally and internationally around the direction of travel with regard to the care of older people, and in particular the requirement for integrated care for older people. So Sláintecare in 2017, when it was launched, had a number of pillars, and one of the key pillars of Sláintecare was the need for integrated care. That came about because it was recognised that even though when people get into the healthcare system in Ireland, their experience of that and their outcomes are very good. So in Ireland, the CSO data would tell us that we have a rapidly aging population, but nonetheless, that population is aging in a way that, by and large, they feel is healthy. So that we have one of the longest life expectancies in Europe. I think at one stage we were top of the table, but we've slipped down perhaps by 1 or 2.
Okay.
And older people report their health in Ireland as being very good by and large. But the problem with the Irish health system, which is common to most Western health systems, is the mismatch between capacity and demand, and also the fragmentation of care and difficulty with accessing care.
Sure.
So Mowlam's strategy in that regard was to think about, well, where is healthcare going internationally? The bread and butter of healthcare is older persons. If you're in a hospital or in primary care setting, the people that you will see around you are older people in medicine and surgery. The only exception, obviously, would be maternity and pediatrics.
Sure.
And even there, the grandparents will be coming in to make sure that everything is okay. So,
yes, yeah.
So healthcare is essentially driven by the needs of older people. They're the biggest consumers. They are, overrepresented in terms of consumption, obviously, by virtue of their numbers. And they're frequent users of healthcare. So Mowlam's strategy is very much not only to integrate in terms of a model of care, but also to look at, well, what are the demands going forward, and what should the model of care look like?
Okay.
So in the last year, we've done a lot of work on fine-tuning our data, looking at, getting insights into who are we seeing, what are we doing, how can we improve the outcomes, what's the sweet spot in terms of intervention and outcomes. So we've been working with a data company that helps us to kind of use various Power BI type applications,
okay,
and gain insights into what we do and how we do it.
Okay.
The other really significant piece of work that we are doing in Mowlam is we're working with the Institute for Healthcare Improvement from the US. And that work is on an age-friendly health system. So again, by virtue of demographics, by virtue of people's experience of healthcare, people's utilization of healthcare, and the multimorbid and complex nature of older people, the Institute for Healthcare Improvement would have developed, through a consensus process with international experts, they would have developed this idea of what constitutes an age-friendly health system to future-proof healthcare systems across the world.
Okay.
So we've been working with the Institute for Healthcare Improvement now for the last year, and we presented in Utrecht about the work we're doing, and we're now part of the European expert group on that.
It's quite an achievement.
It is, yeah.
Yeah.
The international. The International Foundation, the Institute for Healthcare Improvement, is really on a mission in tandem with the World Health Organization to age-attune healthcare across the globe.
Okay.
So in North America last year, for example, the IHI, I think, had registered around 40-odd long-term care residential settings,
okay,
who were age-friendly healthcare systems. So one of the age-friendly healthcare systems would be the Veterans Administration, for
okay,
example. But there was none in Europe. There was none in the UK or Ireland. There were 3 in Australia. And so Mowlam are the first IHI accredited age-friendly health system outside of North America.
Wow.
And we have 20 participant sites who are accredited.
Okay.
We've got another 15 or so in the pipeline to get what's called level 1 recognition by the end of the year.
Okay.
So everything we do now strategically means that we do it through the lens of what is the evidence around, for example, rehabilitation, what's the standards and recommendations around outcomes, and through the lens of an age-friendly health system. So that essentially follows a framework that we apply and we gather data on and we educate the staff on, so on and so forth.
Okay.
So
it's based on a tried and tested international standard, so you know exactly the roadmap that you need to be taking in order
exactly. So it provides us with a common language. So the IHI consensus group, which is a panel of international experts, they looked at 96 indicators of best practice for older people.
Okay.
So if you do the 96, you will get outcomes that are positive.
Okay.
But obviously that's too many for anybody to remember or to apply.
Sure.
So they distilled them down into 4 key indicators, which they call the 4Ms framework.
Okay.
So the 4Ms framework is essentially what matters to you as an outcome: mobility, mental health, and medication.
Okay.
And the evidence is that if you apply those 4 things consistently in every setting with older persons, their outcomes will be better. So we're part of that international movement to age attune what we do, both in long-term care, rehab, or any other service that we're developing, and apply best practice standards. Obviously, that's evidence-based, but measure those and then interrogate how well we're doing what we're doing.
And then use that to improve your services as you go forward.
That's it. Yeah,
amazing.
Yeah,
okay.
Yeah.
So tell us, delving into this new space that you're in terms of a doctor-led service, what demographic typically can a doctor, as you in Mowlam call RMOs, so resident medical officers, for anyone outside of Ireland to know that job title, demographic being 65 and upwards, in terms of mobility, in terms of ailments, what things are people coming through?
So obviously in the partnership we have with Match Medics, the doctors that we've been employing have been specifically employed with the intention of being part of a multidisciplinary team that's applying the national standards and the WHO standards for rehabilitation. So we have a number of units that opened, 4 new units that opened in the last year. There's a number of others in the pipeline. So by the end of this year, we'll be approaching something like 300 rehabilitation beds. Okay. Which is equivalent to one of the kind of level 3 hospitals in Ireland, basically, but dispersed across the country.
Sure.
So the team will be working with older people because, again, they're the bread and butter of the health system. So about 80% of the population within the rehab facilities will be over the age of 75.
Okay.
And when you ask any healthcare professional, did you set out to work with older people as a career choice, they might say, well, not necessarily. I don't want to become a geriatrician.
Sure.
But actually the reality, wherever they will work, be it in anesthetics, in surgery, in any subspecialty of medicine, they'll be working with older people. So I guess coming to work with Mowlam has a number of advantages in the sense that you are exposed to being part of an international movement on age-friendly healthcare, and we can talk a little bit about how they might be involved in that in a while. You'll be part of a national rollout of a model of rehabilitation, which is post-acute rehabilitation, post-acute rehab in the community, within an inpatient setting in the community. And again, all of those elements are novel in that heretofore there wasn't a rehabilitation pathway out of hospital for people, so it either remained in hospital there wasn't sufficient capacity in specialist rehabilitation facilities such as the NRH, nor would their needs have necessitated that.
Okay.
Or else they went home and sought to recover themselves. But we've seen phenomenal results by the multidisciplinary team where people have come to a rehab facility. They may have stayed for anywhere between 20 or even as many as 50 days. But people who heretofore might have been deemed to be inevitably heading for long-term care got back on their feet and went back home.
Okay. So you talked about positive patient outcomes, and that's definitely a big win there. Yeah.
There's one particular example who was in hospital for 7 months. She was on oxygen. She couldn't walk. She came to us on a stretcher. And within 55 days, she was back at home, walking independently.
Wow.
With a frame. So,
okay.
And she came back to visit last week, and she's doing really well. So,
that's amazing.
Amazing.
And we talk about that sort of the public and private relationship, and how, bed capacity being the big words on many people's lips. And if that particular individual had stayed any longer, as you say, they're just the bed taken from someone else, perhaps, who is clogging up the system somewhere else within the healthcare setting. Whereas given this opportunity to bring them into this multidisciplinary team, you're giving this patient incredible outcomes, but also freeing up capacity within the hospital setting. So talk us through, the working in both public and private, working with the HSE for quite a number of years yourself. The politics perhaps that goes on behind the scenes. How did that relationship and the knowledge that you brought in from the public system support with this relationship where you have to work in tandem with the neighbouring public hospital to the rehab facility that you're running at that location?
Yeah, I think the design principles are the same in Ireland as anywhere else in the world. The idea that you need, we know, for example, what the population looks like. We can predict what the number of people might be that would attend the emergency department in any given hospital over the next 2 years. It's usually an increase of about 3% a year.
Okay.
We know the profile of those people, and we know the needs of those people. So when I worked in the HSE in the clinical programs, a lot of the effort was about what is the clinical design principle that you apply, knowing what your demand is likely to be.
Okay.
And again, the Sláintecare policy and international policy is heading towards integrated care, which is about continuity of care, coordination of care, and delivering outcomes that matter to the people who use health services. So those are the three key definitions of integrated care. So they applied in the public sector, and equally now in the private sector, because the private sector has to be part of the solution in terms of capacity, and it has to be designed using the same principles.
Sure.
We have to speak the same language. And in fact, one of the things we're doing, for example, with the National Ambulance Service is they've now chosen to adopt an age-friendly health system approach. They want to become the first emergency medical service in the world to be age-friendly.
Wow.
So we're working with them on people in residential care, for example, for whom transfer to hospital previously might have been the default.
Okay.
And now they'll come in, and from an age-friendly perspective, they'll look at, well, what outcomes matter to this person if, for example, they are, unlikely to benefit from going to hospital. It's not clinically indicated. What's their will and preference? And then they're adopting other principles as well. So the key, I think, between public and private is to have the same design principles, the same standards, the same KPIs, the same common language, the same operational approach in terms of, well, what documentation do we need for admission to hospital or transfer out of hospital?
Okay.
And agreeing on those processes and pathways and the detail of the instrumentation that's used. So in the battery of things that we would do, I was previously involved in the development of the National Standards for Rehabilitation as part of the National Clinical Lead for Older Persons Office, and then we would take.
That's a mouthful.
It is. So NCAGL is the short hand for it. But, so we would have taken those design principles in Mowlam and applied them in terms of outcomes, because very often in the health system, in the public health system, the focus is on activity. How many people did you see? How long did they wait? But not necessarily what were the outcomes.
Okay.
So we spend a lot of time measuring the intervention and the outcome to understand what works for whom. And so, for example, rather than saying, well, 28 days was a desirable length of stay, we're able to measure and justify if somebody goes over that, well, that was the outcome there was really good. The fact that they stayed more than 28 days is of lesser importance.
Okay.
So, in taking lessons from the public sector, I think the same kind of design principles are essentially the thing that needs to apply, adopting the same vision, adopting the same processes, agreeing on integrated pathways. Because ultimately, for example, in our rehabilitation facilities, the individual who's in there receiving rehabilitation, so let's say 2 or 3 times a day intervention by a physio or OT, they have no idea, nor do they care, that this person is actually employed by somebody who is not in the public sector.
Sure.
They what they want is an outcome that will allow them to get back walking, going to the shops, driving, minding their grandkids, hill walking, whatever the outcome needs to be. So we really focus on outcomes as a key determinant of what it is that we are all about.
Amazing. And as you say, just on a wider piece, you mentioned geriatrics. Because of the aging population across the Western world, geriatrics as a specialty has certainly grown quite a bit. When we were back in South Africa in our last roadshow back in March, the idea of geriatrics just wasn't present there, purely based on the lifespan or typical lifespan of a typical patient in South Africa. So those differences are quite large. How then, when perhaps a South African doctor coming across to join Mowlam, do they adjust to that difference in patient in front of them, or how have you found that experience?
Yeah, in fact, it's also true of some of the Pakistani doctors that would have joined us, that that demographic simply doesn't exist. So some of the kind of advantages, anybody who goes and trains and works in any other health system benefits inevitably from that, and it certainly broadens their perspective. Some of those approaches are gaining traction internationally, such as the age-friendly approach. But for any doctor who works in rehab with us, because they're dealing with people with multi-morbid problems, then they inevitably have to pay attention to more than just one thing.
Sure.
But beyond that, they also have to pay attention to kind of family issues, social dimensions. A really important question, for example, for us is, do you have a stairs at home? Because that can determine what happens with you and how long you stay.
Okay.
So any doctor joining us is going to be exposed to a number of things that may not ever have featured in their medical education, or may not have been part of their kind of internship. So one particular person I can think of who's worked with us for the last year, ultimately she wants to go on to specialize in anesthetics. But for her, the exposure to meeting with families, engaging them in facilitating their input into the person's care once they go home, understanding the kind of interventions that we're trying to do, negotiating with team members in relation to how each contribute, being part of a much more kind of democratic team dynamic, being part of developing and fine-tuning key performance indicators, understanding kind of patient pathways and integrated care as a concept, being exposed to age-friendly health system concepts. They're all part of the kind of exposure and education that somebody would get that they may not have got in their own cultural context, or typically in undergraduate training, people are sequentially placed in wherever it is, maternity, peds, surgery, and in rehabilitation, you tend to get a full gamut of issues that interact with one another and impact on the ability of the person to go home. So, for example, is there a carer at home, and do they have the capacity to support the individual? Or is the person themselves who is in rehab a carer, and therefore one of the things that they want as an outcome is to be able to go back and care for their husband or their wife?
Okay.
So those are the kind of, I suppose, hidden dynamics of practice that may not be part of a formal curriculum but are invaluable. The other thing that may be novel to them is how MDTs function, because we're trained in unidisciplinary silos. So when you're suddenly thrust into a situation where you're in an MDT meeting and you need to go negotiate and discuss and understand the contribution of others, again, that's something that can take a bit of adjusting, because therapy teams, health and social care professionals, nurses, doctors work together, but they don't necessarily work in an interprofessional way.
Okay.
And one of the things that might happen in an interprofessional context is that people might take on some of the elements of work that they would consider to be other people's work.
Okay.
And that's something that, again, you would gain from coming and working in that setting for a period of time. Inevitably, our expectation is that people will gain that experience and move on.
Okay.
I suppose the other thing that this is all relatively new. So for example, the rehab service, the first rehab service that we opened on the 1st or 2nd of October in 2024. So we're just coming up to the first anniversary in about a month or so of that service.
To send flowers or a cake to commemorate the date.
Absolutely, yeah.
So that was down in Caracalla.
That was in Caracalla,
yes, yeah.
So, the invitation we would have to staff would be to take advantage of that. Identify something within your CPD requirement that you are interested in. With cognitive impairment, for example, how does that impact on people's ability to rehabilitate? Is there a sweet spot in terms of the amount of time and intervention that's going to maximize your functional ability? Are there particular issues around, other subsets of patients that you as a doctor are interested in? And we have a completely open agenda in terms of, and would encourage people to take on that CPD interest and leadership role. One of our senior RMOs was on a call yesterday, and the rehab facility that she works in is going to be applying within the next month or so to the IHI for age-friendly status.
Okay.
So again, I think there's just one age-friendly rehab facility in Ireland, in Cork. We will have 4 in the pipeline by the end of the year. Okay. So for anybody moving on in their career, being able to lead out an initiative, understand what does it take to bring about a change in a health system? Are there particular methodologies that I need to be aware of in introducing change in a complex adaptive system?
Sure.
As a health system is recognized to be, is all invaluable experience. And so therefore there's a kind of an open invitation and a blank canvas there for people to be able to build upon that.
Amazing. So again, just to frame, it's not a training facility, it's not a training organization, but that, for the right individual, they put their hand up, they, show an interest in a particular area that they see a need for improvement or see a tweak to a process that could be changed slightly, all working towards better patient outcomes.
Yes, I mean, there's opportunities for education and learning.
Sure.
No matter what. Now, in terms of a formal designation of as a training facility, we're working towards that. That's something that's
Great.
Not quite there, but we've initiated a process to look at how we might develop that. From a health and social care professional point of view, we are designated training facilities. So we've got a partnership with Dublin City University, the University of Limerick, that's emerging, and inquiries from nurse training colleges.
Great.
To place students. So we already have students placed by European universities.
Okay.
We will have students placed by University of Limerick. We have students in the pipeline in 2026 from Dublin City University. So wherever we have rehab location, our aim is to partner with the local university for that to become a training institution.
Okay.
And we would hope for the doctors that the same will apply, that there'll be formal training recognition, hopefully. But even in the absence of that being formally recognised, there are all the opportunities to kind of develop your own learning and have that recognised. And very often now, bodies will retrospectively recognise training once you've done the actual substantive piece of work.
Okay. And so there's a lot of sort of meat on the bone there for a doctor to come into, and I know we discussed this before, seeing it as, a great starting point to someone's Irish career to properly understand the real, as you say, the highest consumer of healthcare in Ireland, to then perhaps either stay on, or others have perhaps gone on to various training schemes or other public hospital positions from a starting point in Mowlam.
Yes, and equally, you've reminded me that in some of the interviews we've conducted, people are particularly interested in becoming a GP. And so in Ireland, there is a huge shortage of GPs. The actual age profile of GPs is such that there's going to be a significant requirement to replace retired GPs, and also the profile of current GPs is such that their working lives is very different from a traditional GP who was always available and so on.
Sure.
So I think again, the kind of experience in rehabilitation sets you up really well for that, because a GP has to kind of navigate services. They have to signpost people to healthcare specialists, providers. They have to coordinate care. They're dealing with not just one aspect of the person, but every aspect of their life. So I think one of the things that people did remark on in some of the recent interviews was how they felt there was a good fit with the potential to become a GP in Ireland.
Sure. Okay. While we're in the territory of interviews, you've been working in this space for quite a length of time. I'm sure over time you've picked up your do's and don'ts and what not to do in an interview setting. What do you recommend that people do in an interview setting to, make a lasting positive impression?
I think the principles are the same, for the interviews we would do with doctors as they are with any one of us that's going for interview. I think, fundamentally you need to have a little understanding of who it is that you're going to speak to. What are the kind of things that they're doing, what's their vision and interest. Most interviews these days are competency based, so how does your CV fit with what it is that you're actually going to be discussing in terms of the focus of the role and the nature of the job that you're applying for. And thirdly, I think, just be yourself. I think it's very hard to interview comprehensively for people's technical ability. There's an assumption that we have to make about people's ability to be able to have, their basic medical training and their basic knowledge, but I think it's worth paying attention to what you bring in terms of a person, what you're passionate about, what you're hoping to do in the future, how you see this job helping you towards that, and how you work with other people, because this is a team game, and taking a strong position based on your status as a doctor doesn't work in that scenario. So you have to be able to accommodate other people's views, provide your own expert input, be able to stand by that, but at the same time be able to negotiate with other people. So I think
personality is a big piece in that puzzle then, isn't it?
I think
how much does it come into your hiring decision making?
Substantively, I think, very often the question is, do you like the individual? Do they come across well? Are they appropriate in terms of how they've approached things? Have they done a little bit of research which shows some degree of respect to the role and to the organisation? And then not to be afraid about what it is that they want to get out of the job and to ask about that. How does this help me in my career? And we need to be mindful of that. It's a reciprocal relationship.
Absolutely. And we're forever, when we're preparing doctors for any interview, whatever facility they might be going towards, I'm always of the opinion it's a two-way process, isn't it? You're trying to feel at them as much as they're trying to feel at you. So to just have an open mind then when you're coming to such a setting.
The other thing is, people, not to the same extent in terms of distance, but, I've travelled and worked abroad. It's a big leap of faith to come to a different country, a different culture, a different healthcare setting. It's quite a traumatic move. and we want people to be happy. So it's not. It's about them as a person as well. This is perhaps an exciting juncture in their career. This is something that may result in them working longer term in Ireland or may not, but it's still a very useful experience. But we want them to enjoy the work and feel that it's purposeful and productive,
Sure.
Professionally and personally.
Okay.
And so that's something that's an important consideration as well. We don't expect people to just be robotic in their engagement with the job, and if they're
that's quite refreshing. If I can say, depending on the settings that someone's in, it's not just a job, as you say. You both parties want to get as much as they possibly can out of the experience, whether it's short or long term.
Absolutely. So back to the point about taking advantage of the work that's going on in the background, be it development of rehab or age friendly or whatever it may be, that we want people to come with something that they're passionate about, that they want to apply, that obviously is appropriate in the context of what we're trying to do, and work on that. So for example, one of the things that we're doing at the moment is we're refining a rehabilitation dashboard to kind of capture all the work as I've described earlier on.
Okay.
And that dashboard is exciting because it's the first manifestation that I've seen of the policy on post-acute rehabilitation and how we measure what we do and the outcomes we get and the activity and so on. But, that would present an opportunity for any doctor to take the audit data and to look at that and to say, well, I'm really interested in looking at people with post-acute hip fractures and how do I work with them, because I want to work in surgery in the future or whatever the case may be. So our investment in the person is that they're happy in the job, as well as, feeling like it's a worthwhile role for them.
Okay. While staying in the interview space, tell me, any interview horror stories that you're comfortable sharing with us?
Only my own, Graham.
Only your own.
I can't think of any horror stories, to be honest.
Okay.
I think that it's like any communication process. I think people need to be able to listen and also kind of be clear about what they want. One person that impressed me very much in an interview versus a horror story is the person came into the interview. It was a consultant post, but they came into the interview and they set the agenda very nicely, and they said at the beginning, there are 3 things I want to convey in this interview, and these are the 3 things that I want to get across. And they kind of put their cards on the table up front, and that set the agenda in terms of this person has a mission, they have a purpose, they're clear about things, and they seized the initiative in the conversation. And I thought that was really impressive because it was landed very nicely, but obviously the interview process had to be conducted and gone through.
Sure.
But nonetheless, they were on the front foot.
Okay.
Yeah.
It sounded like you were being interviewed there.
No, not me.
Or the person coming in said,
Yes.
They're the interviewer. Yeah,
absolutely.
Amazing. Tell me then, as a Munster man, correct me if I'm wrong now, but as a Munster man, why should people, consider moving to that part of the country? Why Limerick? Why Clare? Why Munster?
Well, we have facilities all over Ireland, so I wouldn't be selling that point on its own.
Yeah.
But I think that Ireland's a small country, so if you're working in, for example, Ballinasloe, which will be our next rehab facility to open in January, you're in the west of Ireland, you've got access to Europe, particularly I think for South African doctors, they love to travel across Europe.
Sure.
So you've got great access to airports, you've got a really nice way of life, you've got authentic communities who rally round if you need support and that are welcoming. I moved back from the UK, as I mentioned, and we did so because we wanted to enhance our quality of life, and I think the quality of life in Ireland is really good. You don't have the kind of major issues that you might have in other big urban areas. By and large, you don't have a lot of crime. You don't have traffic issues. Transport has improved. Places are accessible. We've got the electric picnic going on this weekend, so you have you have lots of access to international events, international music, and even things in Dublin, such as the West End Plays in Bordgosh Theatre. So, there's more than enough to do. You hop in a car, you're 15 minutes away from the beach. There's a lot going for it. I mean, we were in Greece there a couple of weeks ago, and it was 34 degrees, and it was very hard to kind of function. And I always look forward to coming home because, there's a really good feel living here.
Yeah, and who knew, our temperate climate would be such a selling point nowadays? It really is.
It is.
And we're certainly seeing other doctors from a variety of specialties flocking to Ireland, referencing, I want to be I'm okay with the unpredictable Irish weather because I want to get out of hot, sticky Madrid or wherever other, far-flung, more European, hotter nations. So,
absolutely. Yeah.
Then sort of coming towards the end of our chat today, PJ, as an Irishman, what myth about Irish people would you like to bust today?
Wow. I was asked when I was on holiday where I was from, and the person behind the bar said, we were discussing who drinks the most, and we decided that the Irish were first, the Scottish were second, and the English were third. But in fact, we don't drink a lot. We're moderate drinkers. So so that idea of Irish people being kind of feckless and drunk is not true. We're a very European cosmopolitan population that I think are very international in our perspective, so that's a myth that's simply not true about us.
Yeah, and as you say, a lot more health conscious, right?
Yes.
And parting ways with the shackles of that image of the drunk Irish man or woman that happens to follow us everywhere we go.
That's right, yeah.
Great stuff, Will. Come here. Thank you so much again for taking the time to come up to Dublin today to tell us all about Mowlam, and no doubt there's some future hires who'll be listening to this conversation today, and we'll get a nice glimpse into what it could be like working with Mowlam.
That's great, and thank you for asking, and we're looking forward to meeting our future hires. Yes.
Great. Thank you, PJ.